Good evening, and welcome to the Men's Health webinar hosted by Dr. Michael Belsante with Urology Associates. A couple of housekeeping items before we get started. On the bottom of your screen, you will see a chat box to submit your questions. Those can be submitted anonymously at any time during the presentation. Dr. Belsante will answer your questions at the end of the presentation. At this time, I would like to introduce our speaker tonight. Dr. Belsante is a board-certified urologist with over 11 years of experience. Dr. Belsante practices at Summit. He received his medical degree with distinction from the University of North Carolina School of Medicine. Dr. Belsante then completed his urology residency training at the University of Texas Southwestern Medical Center in Dallas. He then completed a fellowship in reconstructive urology, female urology, and neurodynamics at Duke University Medical Center. Dr. Belsante, we look forward to hearing what you have to share with us this evening.
Thank you very much for the introduction. I appreciate that. I appreciate everyone who's signed in for the presentation. I'm looking forward to hearing your questions at the end, and we'll get right into the presentation. So today we're going to be talking about the signs, symptoms, and treatment options for erectile dysfunction. So this is some of our contact information. This will be up at the end as well if anyone needs to give us a call. So with respect to erectile dysfunction, we want to know what is it, who has it, and what causes it. So what is erectile dysfunction? Erectile dysfunction is defined as the inability to achieve or maintain an erection firm enough to have intercourse. It's incredibly prevalent. Approximately 1 in 5 men greater than 20 years of age will experience erectile dysfunction in their lifetime. More than half of men over the age of 40 will have some degree of erectile dysfunction. And it affects almost 40 million men in the United States, which is a tremendous number. So how does the erection process work? When a man is aroused, the nerves surrounding the penis become active. It causes the muscles around the arteries, which supply blood to the penis, to relax, which allows blood flow into the penis. The additional blood within the penile bodies makes the penis hard or erect. And the erection tightens the veins, which prevents the blood from then leaving the penis and allows the penis to remain erect during intercourse. So what are the causes and comorbidities associated with ED? Well, ED correlates positively with overall poor health. The top 3 physical causes are vascular disease, diabetes, and certain medications. It can be a result of or a precursor to prostate cancer treatment, diabetes, or heart disease. And then we also see on this list pelvic surgery or trauma, neurological causes, endocrine problems or hormone problems, and then other issues. So there is a correlation between erectile dysfunction and diabetes. According to census data, 15.5 million men in the United States have diabetes, and ED occurs 10 to 15 years earlier in men with diabetes. ED is less responsive to oral medications than patients without diabetes and erectile dysfunction. And 1 in 2 men with diabetes have sexual troubles caused by their disease. ED is often more severe in men with diabetes. And in some patients, ED can actually be the presenting symptom of diabetes, meaning that people discover they have diabetes because of the erectile dysfunction that they experience. So what factors increase erectile dysfunction in men with diabetes? Well, age is definitely correlated with erectile dysfunction. The duration of diabetes, so people who get diabetes earlier in their life will have more severe or earlier onset erectile dysfunction. Poor control of blood sugars correlates with erectile dysfunction. The presence of what's called microvascular complications or disease of the small blood vessels of the body will affect erection health. Diuretic treatment or other blood pressure treatment, and also the presence of cardiovascular disease will be affected as well. So men with diabetes are at a higher risk for heart disease. Diabetes and heart disease can increase the likelihood of experiencing erectile dysfunction, and having diabetes almost doubles the risk of a heart attack or death from heart disease. Men with diabetes and erectile dysfunction may develop coronary artery disease, which is what causes heart attacks, 2 to 3 years after impotence, and likely will experience a cardiovascular event, which is something like a heart attack or stroke, within 3 to 5 years. So talking with your primary care doctor about your erectile dysfunction symptoms can actually help to identify progression of heart disease or reduce the likelihood of a heart attack or stroke. We like to say that erectile dysfunction is sometimes the canary in the coal mine. It's the first presenting factor for underlying heart disease or diabetes. So erectile dysfunction and heart disease, it may be a warning sign of more serious issues, as I was just saying. Erectile dysfunction can be an indicator of what's called silent or non-symptomatic coronary artery disease. ED is an independent risk factor for future heart events and can be correlated with the extent of heart disease. So men with more severe heart disease tend to be more likely to have erectile dysfunction. Erectile dysfunction precedes coronary artery disease symptoms or silent coronary artery disease in almost 70% of cases. What that means is that men will oftentimes present with erectile dysfunction prior to having the typical or more, what you would think of as more common symptoms of heart disease. So this kind of goes along with that. Arteries supplying the penis are smaller than those supplying the heart. So blockage creates reduced blood flow, which will affect the smaller arteries before it affects the larger arteries. So you can see here that the arteries that supply the penis are only 1 to 2 millimeters in size. So when you have a blockage of that artery, it's going to affect the erections. Whereas when you have a more significant blockage, it will affect the main arteries supplying blood to the heart, which are 3 or 4 millimeters in size. And then the heart arteries supplying the brain, which are the carotid arteries, which are 5 to 7 millimeters in size. And then finally, the arteries that supply your legs when you walk, which is the femoral artery, which is very large at 6 to 8 millimeters in size. So if you have equal amounts of plaque or hardening or calcium deposits in the arteries along the inner lining, you're going to have symptoms in the smaller arteries before you have symptoms in the larger arteries. So what about the correlation between erectile dysfunction and prostate cancer treatments? So the nerves that provide stimulation for erections lie very close to the prostate, and they can be injured during prostate cancer treatment even when you try very hard to spare those nerves. So prostate cancer treatments can actually affect a man's ability to get an erection on either a temporary or permanent basis. What you see here in this slide, and I like the way that this slide is put together, is that when we remove the prostate, you're disrupting the pathway of urine, but you're also disrupting those nerves that go along the urethral sphincter, along the bladder, and along the bottom side of the prostate. So we remove the prostate, we try to spare those nerves, move them off to the side, and then sew everything back together. But even when you spare those nerves, they can become injured or disrupted or even just shocked, and it can take a while for the erection function to come back. So what are some of the restoration treatment options that we have for men with erectile dysfunction? Well, they can be categorized in 5 basic categories. We have oral medications, which are like Viagra, Cialis. There are injections, where a man will give himself an injection into the penis. There is a penile implant, which is a permanent solution, which is very nice in a lot of men. There's a vacuum erection device and something called a urethral suppository, and we're going to go over all of these options here. So what about the oral medications? These are also called PDE5 inhibitors. How do they work? Well, they work by increasing blood flow to the penis, which may improve the ability to get erections and maintain them until sexual intercourse is completed. It does require sexual stimulation. I tell all my patients that I put on one of these medications that you can't just take your Cialis or take your Viagra, sit on the couch and watch your favorite show and wait for your erection to appear. That's not how these medications work. It usually takes about an hour for the medications to work before sexual activity, and usually will work for about 4 hours. Although with Cialis or tadalafil, which is the generic for Cialis, it can actually work for quite a bit longer. So you can't take more than one of these medications in a day. And some of the medications' efficacy can be affected by food. So Viagra, for example, I tell people to take it about an hour to an hour and a half prior to intercourse on an empty stomach. How effective are these medications? Well, they're effective in approximately 50 to 85% of cases. Almost half of men with erectile dysfunction after prostate surgery will give up on the pills, or the pills stop working. And men with diabetes are 1.5 to 2 times more likely to move on to other treatments. The most common side effects of these medications are headache, facial flushing, stuffy nose, or upset stomach. And there's some cautions to be given with these medications. Always talk to your doctor if sex is inadvisable because of cardiovascular status. If you're taking an alpha blocker like Flomax or doxazocin, generally you need to have been on that medication for a little while before you would start taking these medications because they can act together to decrease blood pressure. With nitrates like nitroglycerin, you want to talk to your doctor. Nitrates cannot be taken with these medications. It can cause a fatal drop in blood pressure. So never ever take one of these medications if you're on nitroglycerin or other nitrates for chest pain. So tell your doctor if you've ever had any heart problems, stroke, low blood pressure, or high blood pressure, or if you have any liver or kidney problems. So the vacuum erection device is another option for men. The way it works is there's a hollow plastic tube that's placed over the penis. There's a pump that's used. It's either hand operated or battery operated, and it causes a vacuum. The vacuum pulls blood into the penis, which allows for an erection to occur. And then an elastic ring is placed around the base of the penis, which allows for the blood to remain in place. Patient satisfaction rates range from 68 to 80%, but despite high initial success rates, in one study, 86% of men decided to move on to other options. So the most common side effects are blocked ejaculation because of the ring around the base of the penis, bruising of the penis due to the vacuum device, penile discomfort or a sensation of numbness or coldness in the penis, again, because of that ring. The most common reasons for discontinuation are the erections aren't hard enough or don't last long enough, the difficulty in mechanics, penile bruising, or a lack of spontaneity. The urethral suppository is a medication called alprostadil. The brand name for it is Muse. The way it works is it's administered by putting a little stem or a little applicator into the urethra after urination. The pellet is then inserted into the urethra. The onset of erection is within 5 to 10 minutes, and you have to have that suppository refrigerated. Success rates are about 40 to 65%. 40 to 50% of men don't continue using this therapy after 6 to 8 months. The most common side effects are pain in the penis, which is common with that particular medication, alprostadil. You can also have pain in the urethra or testicles, urethral pain or burning just from putting that stem in the urethra. Low blood pressure or dizziness can also be an issue. Most common reasons for discontinuation are, again, it's not sufficient for getting a firm enough erection for intercourse, or the pain or burning is another reason men stop using it. We talked a little bit earlier about injections. So how does that work? Instead of doing the pellet, you're actually injecting a medication called alprostadil, and there are other formulations. There's one called Trimix, which is a mixture of alprostadil and 2 other medications. It's injected directly into the corpus cavernosa, which is the erectile body of the penis. It takes about 5 to 20 minutes to work. It's effective in about 60% of patients who are satisfied and will continue with it. But despite the success rates, in a study of 250 men, only 20% continue using the therapy. Again, the most common side effects are penile pain, fibrosis or scar tissue from repeated injections into the penis. Very rarely, priapism or prolonged erection can occur, which can lead to the need to go to the emergency room or to the physician's office for management of that, or blood collection under the skin at the injection site. And the most common reasons for stopping this type of therapy is that, again, the erections aren't satisfactory, pain, or just people don't like giving themselves a shot in the penis, surprisingly. So next, we're going to talk about the penile implant. So the way a penile implant works is a pair of cylinders are implanted into the penis surgically. There's a pump that's placed inside the scrotum, and a reservoir of saline is placed into the lower abdomen. The way it works is the pump is squeezed and released, which moves fluid from the reservoir into the cylinders, which creates an erection. The device is then deflated by pressing on a small button on the side of the pump. The penis then returns to a flaccid or soft state, which is very natural looking. Nobody can tell that a person has this. It's all self-contained on the inside of the body. 98% of men reported that the erections are excellent or satisfactory. And at 7 years after implantation, 94% are still in use and do not need to be revised. The most common side effects include postoperative pain, which is true for most surgeries, Mechanical malfunction, which can include what's called autoinflation, where the lockout valve can be a little bit faulty and cause some of the fluid to go into the penis automatically, or infection, which is rare but a serious complication of a penile implant. This is a video which I'll narrate, which kind of demonstrates the way this works. Again, this is just intended for basic education on how the penile implant operates. So this is a patient with a penile implant. What you see here is no one can tell it's there. On the inside, there are these two cylinders. The patient is pumping the pump, which drives fluid from the reservoir into the cylinders, which causes a firm, rigid erection. It will stay firm for as long as the patient wants it to stay firm. The button is pressed, which then allows for the fluid to go back into the reservoir, and the penis returns to a flaccid state. So very easy to use, and again, everything is all self-contained. So what are the benefits of a penile implant? Well, it's designed to be a permanent solution for erectile dysfunction. It's spontaneous. You don't have to carry medications or a vacuum pump, or you don't have to have anything refrigerated. So when the mood arises, the patient can have sex. The erection, as I said, will last as long as the patient and his partner desire. It's entirely self-contained. No one knows you have it. There are high rates of patient and partner satisfaction, which is important. It typically does not interfere with ejaculation or orgasm. The implants have been in use for over 40 years. These are not new devices. They've been tried and true. And almost 500,000 men have been treated with this, with these implants. So it is a surgical procedure, as I mentioned. So any surgical procedure, there are possible risks. Not all patients are candidates for a penile implant. So of course, a patient would have to discuss this with their doctor ahead of time to know if a patient is a good candidate for this. So some of the risks of the implant are mainly, if you decide to go with an implant, it makes a natural or spontaneous erection impossible. So once you cross that bridge and go with the implant, you can't then go back and say, you know what, never mind, I want to do injections or I want to try pills. So this is usually tried after those other things have failed, or when a patient just knows they don't want to try one of the other options. The implant is a mechanical device. There's tubing, there are connections, so sometimes there can be a mechanical failure, which would require a revision. If the implant needs to be removed or replaced, the penis may become shorter, curved, or scarred, and that's true for any operation that requires repeat procedures. Of course, anytime someone has an operation like this, there may be pain involved. And men with diabetes, spinal cord injuries, or open infections can have an increased risk of infection. So just to summarize, erectile dysfunction is a common problem, and it can be associated with other health conditions. There are a wide variety of treatment options. Penile implants can offer a permanent solution. Of course, the patient and their partner should talk about what works for them. And of course, you're going to want to talk to your urologist, who is hopefully an expert in erectile function and can go over all of these options with you. So I'd like to thank you all for logging on, and of course, we'd be happy to see you in either in my office with me or with one of my partners who offers these options. And I'm looking forward to hearing any questions you all may have.
Thank you, Dr. Belsante, for sharing this information tonight. At this time, I'm going to introduce you to a patient who has the penile implant. I will keep his name anonymous. He has volunteered to share his experience as he wants to help other men. So at this time, I'll take his microphone off mute and let him speak. And then after he speaks, Dr. Belsante, we will move into the Q&A session.